Good afternoon, everyone. Good evening. My name is Dova Levin. I am the Senior Director for Program Management and Education at the Myasthenia Gravis Foundation of America. Today on our MGFA Wellness Series, we have Men's Health with Dr. Mark Terrelonge Jr. Dr. Terrelonge is a neurologist who cares for patients with nerve and muscle disorders, including ALS, inflammatory nerve diseases such as Guillain-Barré syndrome, and disorders of the neuromuscular junction such as myasthenia gravis. At the University of California, San Francisco School of Medicine, Dr. Terrelonge serves as an assistant director for the residency program in neurology and as a lecturer on weakness related to neuromuscular disorders. Other endeavors include developing satellite clinics for people with ALS or other neuromuscular conditions who live in rural areas of Northern California. We do want to thank our sponsors today that help us bring this program to you: Alexion, Argenx, UCB, Horizon, Janssen, and also Caballetto Bio. So I'm going to stop sharing and I'm going to allow Dr. Terrelonge to share. And as we go along, please put your questions in the Q&A box, and we will get to them at the end of the presentation. Thank you.
Perfect. Just checking that everyone can see my screen. Perfect. So hello again. My name is Dr. Terrelonge. I am centered at the University of California, San Francisco, and I want to thank Nova for an amazing introduction. And today we're going to discuss myasthenia gravis and men's health, and what aspects actually cross over with men's health and what things might be separate, and go from there. So for my first slide, when thinking about men's health, I start off with this picture here. A lot of the men's health magazines that I'm sure that many of you see oftentimes really focus on things such as fitness and making sure that you remain lean, having low fat. Oftentimes there's a lot of material inside of them on things such as what's going on with testosterone in the body. And all of these things are very important to men's health, even though it doesn't necessarily have to do with the way that you look. It has more to do with the way that you feel. Another thing that oftentimes is in these types of magazines too is thinking about healthy aging in terms of when we get older. How do we make sure that we are able to maintain health and maintain not only muscle mass, but blood pressure and the things that help us actually feel well. These magazines do this to an extent and maybe are more related to cosmetics, but we'll talk about things that are done to be able to help us feel that way in our own communities and with our own families. So first, what is men's health? It's any issue that exclusively affects those who identify as men, or it could be any issues that disproportionately affect those who identify as men, or any issue at all that affects men. So pretty much all health disorders can affect men, but we'll talk about those that are myasthenia related that men might have to deal with more frequently today. When we look at lists of what are the 7 issues that oftentimes come up in men's health related to surviving or remaining healthy, this is the list that we usually see. There's hypertension, heart disease, obesity, cancer, diabetes, accidental injury or poisoning, which affects men disproportionately more than it affects women. And then more recently, what has bumped up to the top of the list is COVID-19 and other respiratory illnesses. This as COVID-19 is probably decreasing in terms of both its frequency and incidence with increased vaccination. But as you all may notice this year, the respiratory season is still quite active with a lot more flu. And then for children, RSV, even though it's affecting adults too. And given that myasthenia affects breathing, this is crossing into this. There are other issues that also affect men's health, including fertility, libido, that we'll talk about later. But these are the 7 main things that oftentimes are at the top of most men's health lists. Of note, all of these things can also affect women, but we'll talk about how they're in particular related to men. So a lot of the reversible causes of men's health issues, these are things that have to do with behavioral changes that lead to some of the issues with health, are that men are in general more likely to drink alcohol and smoke tobacco. And drinking alcohol to a significant degree usually means drinking more than 2 drinks in a single day or more than 14 drinks in a week. And then smoking tobacco. It's been shown that actually even smoking 20 cigarettes in life over your entire lifespan increases your risk of having things like an aneurysm in your aorta by about 10-fold, and then more can cause other issues. I think people oftentimes are most worried about cancer, but usually it also can cause emphysema and other changes in the lungs that might not be cancerous, but can affect breathing later on. Another thing that oftentimes is a big reversible cause of men's health issues is that men are more likely to make risky choices. There's a huge risk increase for men that happens between around 18 to 28, where if you look at most mortality curves, the main reason why there's a big difference between average lifespan for men and women is because of what happens in that group, where men are more likely to do more dangerous things with cars, not have helmets on bicycles, use motorcycles without appropriate protection, things like that. The last one, and this is probably one of the easiest ones to reverse and might even help with some of A and B, is that men in general are less likely to see a doctor for regular checkups. I think that's less likely going to be the case for this group, or men who have myasthenia gravis, as you tend to have a relatively good relationship with your neurologist, and thus probably also a good relationship with your primary care doctor. So a lot of things that can sometimes be missed, such as late stage cancer, hypertension that's gone on for a while, that is not treated with blood pressure medicines, are more likely to just be treated, because as you go to your physician's office more frequently and have your vitals checked, a lot of these secondary measures are also being looked at. In terms of myasthenia gravis and how it affects men, myasthenia gravis actually happens less frequently in men. It happens much more frequently in women, with about 60 to 65% of cases actually happening in women, and only about 35 to 40% of cases happening in men. Additionally, men who have myasthenia get it much later in life. There's 2 main peaks of when people get myasthenia. We always say there's a peak in the 30 to 40 range, and there's another peak after 50. The red bars here represent women, the blue bars here represent men. You could see that essentially before 50, it happening in men is actually quite rare. And then after you get past 50, there's a huge spike, especially in that 60 to 70 and 70 to 80 range. And I would say that for me, most of the patients I see who are men are here. I have occasional ones here, while women instead tend to have their myasthenia first happen when they're in their 20s and 30s, though they can still have it later on in life. The reason why I bring this up is that whenever people think about a lot of the disease burden that happens from myasthenia and other possible conditions that you might have, those who have myasthenia who are men more likely got a lot of their comorbidities, such as hypertension, obesity, before they actually had their diagnosis, as opposed to women who might actually have those secondary to some of either the therapies or things that they had with their myasthenia. So for men's health, the issues that are comorbidities tend to co-run with the myasthenia, as opposed to being a direct consequence of the myasthenia, though there is some interaction, as we'll see on the next slides. So what things does myasthenia put you at higher risk for? One of them is fatigue. I'm sure all of you know this, and fatigue is it has a pretty open definition. Fatigue can be feeling tired and sleepy, or it can have to do with ability to mount energy after a period of time, which is the literal definition of what happens in myasthenia whenever you have that impaired connection between the nerve and the muscle due to the receptor. Depression is a lot higher in myasthenia. It's not known completely whether this is directly just from the effect of having a chronic disease and the risk of depression being higher, but or if it could have something to do with the underlying mechanism. But we do see it more frequently. Thyroid diseases, and this includes both autoimmune thyroid diseases, hypothyroidism, and hyperthyroidism, tend to be slightly higher in myasthenia. Granted that for those, the thyroid diseases are seen much more frequently in women compared to men. There are oftentimes whenever you have one autoimmune condition like myasthenia, your risk of having another one is higher too. And the main autoimmune condition that we see that concurrently runs with it is thyroid issues. And then the fourth one is diabetes. The diabetes is hard to sometimes separate out whether it's diabetes that is also partially autoimmune, and that a lot of diabetes is autoimmune, even if it's type 1 or type 2. The second would be whether some of the medications that we take for myasthenia actually increase our risk of having diabetes. And then the third being, is there any relationship between what myasthenia itself does with sugar metabolism, even though that third hypothesis is not the greatest. But these 4 conditions we do see more frequently in men. What does myasthenia not affect? Myasthenia does not affect fertility. So people with myasthenia are not any more or less able to produce children or have any issues with sperm or hypogonadism or inability to use their hormones to be able to do the things to make babies. Myasthenia does not affect erectile function. So though the penis has muscular tissue, that has much more to do with blood flow, more so than it being related to the way that the nerve and the muscle connect. So erectile dysfunction is not seen in myasthenia. And then the third thing is it shouldn't affect libido itself. Libido could be affected from some of the other changes, such as medications that you might be taking or depression, but it shouldn't be affected by myasthenia itself. Term for myasthenia treatment, as we've been kind of alluding to so far, side effects of treatments are likely the biggest contributor to issues of men's health. And that is largely dependent on both the duration, the dose, and what other comorbidities you have that may affect the way that these treatments affect you. Take a short break and just take a look at the Q&A and see what's happening. I will answer Jeff's question just a little bit later to go over things that are biological versus sex and gender, but gonna just leave it in these terms for now. The first medicine that I want to discuss is it's probably a medicine that almost all of you are on or have been on at some period for your myasthenia is prednisone and the many different effects that come from that. It probably doesn't need a slide from me. You all probably have lived these, but the biggest prednisone side effects include emotional lability, which is ability to get to either very high highs and low lows, anger, depression, and to feel like you're almost swinging between those pretty quickly. I think that prednisone oftentimes gets a big rep for causing a lot of aggression, but outside of aggression, it can also cause irritability, which will feel different than aggression, is probably felt more inside of the body. And then also those very quick mood swings. Depression is a side effect of prednisone. Hair loss is a side effect of prednisone, along with the skin becoming much more thin and having increased risk of bruising. Prednisone, when taken for a long time, can also lower serum testosterone, which we'll get a little bit more into, and why it might be important to have that tested by your primary if you've been on prednisone for a long period of time. Prednisone itself can decrease libido. Prednisone leads to weight gain. And then the reason why most people who are on prednisone get DEXAs every 2 years is that prednisone decreases bone density quite a bit, which can change, increases your risk of fractures or other injuries that happen at the ankle or other locations. With low testosterone, it almost can do a double whammy on all of the things that prednisone does on its own, which it doesn't have to do through only lowering testosterone. Whenever you have low testosterone, you can have loss of muscle mass and strength, which when combined with myasthenia can make you feel weaker. Low testosterone also changes your fat distribution. And with myasthenia, as you know too, that whenever you take prednisone for a long period of time, there's an increase in the amount of adipose or fat tissue that might deposit around your body, either around the neck or around the abdomen or around other areas. It too worsens bone density. It too can lead to hair loss. Low testosterone can affect mood and make you more depressed. It can make you more fatigued. It certainly will decrease the sex drive, and that itself can also cause erectile dysfunction. So both the steroids themselves can lead to these, and then also the steroids' effects on testosterone can worsen some of those earlier effects too. Okay, I'll leave Mike's question also to the end too. Mestinon, which many of you also may be on, because it does work on cholinergic tone, can also lead to emotional lability. I think that the main side effect that people mostly hear from this is that their GI system can be turned up, that they can have increased tearing and saliva. But the emotional feeling of being more anxious can also happen from being on methadone for a long period of time. For hair azathioprine, which might be a drug that many are also on as a medicine to be able to help decrease the amount of prednisone that you're on long term, can also cause hair loss. So if you've been having any issues with hair loss and you're on this medicine, this might be contributing to it too. The other medicines, some of the other medicines that we use for myasthenia don't actually have any major men's health side effects, including rituximab, plasma exchange, or IVIG. They do have side effects on their own, even though for the most part, they're all pretty well tolerated, but none of them should affect any of those primary men's health issues. Perhaps IVIG can increase your blood pressure temporarily while you're having it infused, but usually doesn't lead to long-term blood pressure changes over months and months. For those medicines that we talked about ahead of time already, prednisone does have direct effect on hypertension, obesity, diabetes, and I think that this is probably one that many people here probably experience, that when you're on prednisone for a while, it changes the way that your body's able to deal with sugar. So your blood sugars do tend to rise up. And sometimes they can rise up to the 300, 400 range when they're supposed to be normally in the high 90s and low 100s. And some people even have complications from that diabetes that are worse than the myasthenia itself. And the two can start to interact with each other because they can create illness. And then prednisone doesn't cause any worsening of things like COVID-19. But for certain respiratory illnesses, if you are immunosuppressed on prednisone for a while, it can increase your propensity to be able to have some of those other respiratory illnesses come up. For other immune suppressants, this is likely something that, or hopefully something that your neurologists have discussed with you, that when you're on agents like azathioprine or Cellcept, that there is, even rituximab, there is a slight increase in your risk for cancer. And that because the immune system takes part in doing two things. It helps, or many things, but it helps fight infection. But it also is one of the early detectors of cancer cells that are in your body. So if you have, when your immune system is down, your risk of having some indolent cancer that your immune system might have been suppressing for a long period of time does increase a bit, which is why for several of the medicines, including Cellcept and azathioprine, we ask patients in particular to get skin checks with their dermatologist every year or every couple of years, just to make sure that they're not at increased risk for that. And then those immune suppressants also can increase the risk of certain respiratory illnesses. And then with rituximab in particular, it decreased the efficacy of the COVID-19 vaccine for a period of time, though. So for a lot of people, they had to either get revaccinated or try other kinds of monoclonal antibodies with COVID-19 to make sure they kept themselves protected. Fatigue certainly can happen from having myasthenia on its own. And when you're fatigued, you increase your risk of having hypertension, heart disease, obesity, and respiratory illnesses. And that fatigue kind of can become a circular, a back and forth, where as you become more fatigued, these other things get worse. And then as those get worse, your fatigue gets worse, which is why fatigue is one of the hardest things to treat in myasthenia, because it doesn't only depend on the myasthenia being treated, but on oftentimes comorbidities that can interact with it also being treated too. So with this, one thing that we oftentimes tell patients whenever they have myasthenia is that our goal is always to keep the myasthenia gravis under control with the least amount of steroid possible, because that steroid can really change the way that if you're on high doses of steroids to control your myasthenia, some of the side effects of it can affect your health quite significantly. Therefore, your doctor probably is working with you towards using some of the older immune suppressant agents such as azathioprine or Cellcept, or even now some of the newer ones like Vyvgart or Solaris, to be able to help decrease the amount of steroid you're taking to be able to help keep you healthy. Otherwise, as those other things that are not caused by myasthenia, but caused by the things that we do to you for myasthenia, can actually cause more issues. This last piece that I want to make sure that we discuss too today is depression, as I think this is something that definitely affects men much more, or men tend to suffer with depression more than women with myasthenia or women in general. In clinic, there's a lot of scales that we oftentimes use, but one of the best ways to be able to tell whether you have depression is actually a mnemonic that we have called SIGI caps. And we essentially are looking to see if you have 5 of the following 9 types of things that have changed in your life, and that they've changed for more than a couple of weeks, which might be a sign that you are depressed. It's not only mood. One of them is sleep, and this could be either a drastic increase in sleep where you're sleeping for, say you normally slept for 6 hours, but now you're sleeping for 9 or 10 hours to feel rested, or only sleeping for 2 or 3 hours. That could be a sign of depression. Second is loss of interest in activities that you like to do. So if you were either a chef or you like biking and it's outside of just the fatigue, it's just that the activity itself just no longer feels interesting, that can be a sign of depression. Third is guilt. So feeling guilty about anything, or feeling guilty about things that you've done, or feeling increased worry about things that you've done is a sign of depression. Fourth, and this one is almost always down, but a major change in energy. And this one is interesting because feeling like you have low energy from a condition such as a disease like myasthenia gravis can lower the way that your energy feels in total, which increases your propensity to have depression. So if you're feeling low energy from that, it's sometimes not good to only say it's only from the myasthenia. It could also be from a mood change. Fifth, a change in concentration. So not being able to even sit through, say you're able watching the news at night and you're not able to sit through and watch a full news series, or you can't sit down and read a book, or you can't do the entirety of a task, could be a sign of depression. Appetite going either way down or way up. Psychomotor disturbance. This one usually has to do with how much you're moving. So if others note, for example, that you seem more fidgety than normal, or if they notice that, for example, whenever they're talking to you, that you're either slower to respond, or that you're less responsive to anything, like if you're with your partner and you're even just having a conversation and you're just less responsive or answering questions, that's one sign. Whether you feel it or not, it's something that can oftentimes be seen only by others. And then suicidal ideation, or feeling as though you're either having any thoughts about harm to self, or even thinking about questions such as, why am I living, or what's the purpose of living? So having any 5 of those might be a sign of it. As I just discussed before, that men report depression to usually a greater extent than women. This is in any type of clinic, but they're much less likely to also be prescribed any medications for it, or to have a counselor, or even think of any of the other first steps that they might use to be able to help themselves with it, which could even be going to church, talking to your friends, other things, which is usually a sign of under treatment. And the reason why this is important is that even though myasthenia itself does take a large part in affecting quality of life, whenever people are also depressed, which is, we know, is much more frequent whenever patients have myasthenia, when you think of the things that actually lead to quality of life, so here it's things like social participation, so sense of belonging, feeling like your life has a structure, feeling that you have self-worth, feeling that you're safe, feeling that your body works and does the things that you want it to do, or bodily integrity, having inner contentment, and then actually doing meaningful daily activities. While you could think of how myasthenia can certainly affect bodily integrity and even ability to do meaningful activities, and might affect your social participation based on if you can't see well, if you're having double vision or other things. If you are depressed, your quality of life will certainly go down, because it will affect almost all of these different domains, and can actually affect you more than the myasthenia itself. And then again, co-interact with the myasthenia in ways that will make you feel worse, when sometimes we'll think that what we're trying to treat directly is the myasthenia, but sometimes it's the underlying depression that can lead to more improvement. So in summary, just to go over how myasthenia works with men's health, is that it has a baseline increased risk of thyroid disease, diabetes, fatigue, and depression. And that men generally get myasthenia gravis later in life. So many of the men's health issues that we think traditionally of, such as hypertension, obesity, etc., are things that people have had prior to them having myasthenia, more so than the myasthenia leading to it. Medications for myasthenia may create health problems, And generally minimizing steroids to the lowest dose possible will help minimize some of those extra health problems that we see, though other medicines do still have some risk, for example, immunosuppressants in cancer. And then fourth, and I think probably one of the most important, is that depression is much more likely to be undertreated in men and can significantly worsen quality of life. So always discuss with your doctor if you think that you may be depressed, because there are probably things that could be done, whether medication or not, that might be able to still help with quality of life or otherwise. So I will switch it over to questions about specific things that people might have in terms of myasthenia gravis and their quality of life. So I'll ask Dova if it's better to do it by reading them off of the Q&A or if there's a different format.
Yes, go ahead and read. Not everyone can see the questions.
Okay.
So I'll read it to you and then you can answer.
Okay.
The first question is, isn't it confusing to include females who identify as male in this presentation? The statistics and biology that apply to men won't apply to females identifying as men, correct? Otherwise, the title for this presentation seems meaningless.
Well, I think that I think it depends, because I think a woman who a female who identifies as male, or someone who's trans, might have the same issues with depression. But things, for example, about like erectile dysfunction may not apply to them, but I think they could listen to the presentation for whichever parts they think apply or not. So I think that the issues that affect women's health, including things around cervical cancer, uterine cancer, menopause, etc., I didn't cover and perhaps wouldn't be applied to this conversation, but I think most of the other things maybe gender or applies plus minus, but a lot of things, again, they affect everyone, they just affect men more.
Thank you. The next question is, I'm on Mestinon and prednisone. I've developed bladder control issues since starting. Would that most likely be due to prednisone or the Mestinon?
That could be, interestingly, from both. Mestinon, because it does affect the cholinergic system, can change the way, oftentimes not that the bladder works, but sometimes the way that the sphincter works. So, but usually it's not a lot. Normally the Mestinon really affects the GI system and pushing through things on that system much more than the genital urinary system. I guess it's a little bit hard to do back and forth here, but if that person has tried stopping or decreasing Mestinon to be able to see if they've noticed that their bladder issues have improved. The other things for steroids is that depending on the dose of steroid that you're on, steroids, when used at certain doses, can cause muscle disease separate from the myasthenia. And that muscle disease can sometimes lead to weakening of other muscles. And those muscles tend to be the ones around the hip girdle and those around the shoulder. Depending on, it might not be that the bladder is weaker, but it could be that some of the muscles around the bladder have changed in strength. And that could change the way that urinary dynamics work. So it's possible. It's hard to say always without looking at someone's total list of medications, but those two are not high offending agents for changing bladder function, but there are theoretical ways that they could. And then for 35 milligrams of prednisone, depending if you've been on it for a while, it certainly can change. You could potentially have secondary muscle issues related to being on steroids that high for a while. So it's something that you could discuss with your doctor.
Thank you. Does long-term use of Cellcept cause you to have tremors? I had slight tremors before I started Cellcept, but it is worse now.
Cellcept certainly can cause tremors. It can worsen people who have baseline tremors. Most patients do not have worsening of tremors on Cellcept, but there are a sizable minority that do. You can treat those tremors using the traditional medications that we use for treating tremors, such as beta blockers, or in some cases primidone. Beta blockers probably more. But one thing that we generally don't like to do is, if you have a side effect of a medication, keep giving additional medications to try to beat the side effects, because you'll just keep adding more and more. So it's depending on how much the Cellcept is doing for your myasthenia, that's something that the discussion that you can have with your physician is either is it worth it to do more CellCept or to do less CellCept, depending on how my myasthenia is controlled to see if the tremor gets better versus thinking about another med versus some people would say, keep the tremor or try a different med, but it certainly can worsen it.
Perfect, thank you. So I have one question for you. Has anyone studied or do we know why there's such a difference in myasthenia onset between men and women?
Yeah, that's a great question. And it's been something that people have positive answers about, whether it could be something to do with hormones and like the timing of them in terms of when they increase in men versus women, or haplotypes that are more frequent in men or women, but it's not really known why, and it's still one of the mysteries. I think as there's more genomic studies, and there's also more of the things such as gut biome studies, which, for example, for MS have shown that things like mononucleosis almost come before that. We may find that there's some other risk factor that turns it on at a certain time of life, and that people just have a propensity for it for a while, but we don't know what that is exactly right now.
Got it. Well, thank you so much, Dr. Terrelonge, for this presentation. We appreciate it, and it will be available online for people to watch afterwards. So thank you, everyone. Everyone have a safe and happy Thanksgiving. Thank you.
Thank you.
Bye-bye.